Welcome to Your Case is on Hold, a JBJS podcast hosted by Antonia and Andrew Schoenfeld.
Here, we discuss the science in each issue of JBJS with an additional dose of entertainment and pop culture.
Take us with you in the gym, on the commute, or most certainly, whenever your case is on hold. Welcome back, everyone, to Your Case is on Hold. It's October. It's Halloween season, so this is Happy Halloween from the Your Case is on Hold team. I am Andrew Schoenfeld, Deputy Editor for Methodology at the Journal of Bone and Joint Surgery. We all float down here.
I'm Antonia Chen, Deputy Editor of Adult Reconstruction, and everything flows downhill here.
Downhill. We all float down here. It's an It reference because it's Halloween. You know what I'm saying?
And I'm just saying everything rolls downhill in practice.
What's your favorite scary movie?
Oh, that's a good question, actually. I mean, I'm old school. Like Chucky is what I grew up with.
Yeah.
What about you?
The Exorcist.
Ooh.
Sure.
Yeah, I can't sleep well after that.
Watch that. Don't sleep with the lights off. This is episode 20 of Your Case is on Hold. They've been letting us do this for 20 episodes already, and boy, do they regret it. We are covering the October issue of the journal. This is going to be the JBJS that's released on October 19th. So just in time for the scary season. For those who have been listening, as you all know, the opinions and the frightful stories that you will hear here are mine and Antonia's alone and do not reflect the official policy of the journal, the board of trustees, or the publisher. Please do check us out on Spotify, Apple, wherever you get your podcasts. Check us out at jbjs.org. Please give us a 5-star rating and do subscribe so you don't miss any of this fast-paced research action. This issue, the Halloween issue of JBJS, is brought to you by Clinical Classroom, and definitely check that out for lifelong educational opportunities. We have a special announcement. Special announcement. This is a you heard it. We got the horn and the bell for the special announcement. This is about large database and registry research in joint arthroplasty and orthopedics from our editor-in-chief, Dr. Swinkowski. It is permanently free. We do have, so definitely take a look at that. And then on top of the pile, we also have another permanently free article, What's New in Shoulder and Elbow Surgery by Kim and colleagues, an organizational approach to addressing racism in orthopedic surgery by Brooks, and What's Important, Alternative Advanced Dissection, Arts and Humanities by Velicki, which is also permanently free. This will now bring us into our headlines. I will go first, speaking about the therapeutic effects of conservative treatment with 2-week bed rest for osteoporotic vertebral fractures, a prospective cohort study by Funayama and colleagues. This does have a commentary, so you don't have to take my word for it. You can read what others think about this very interesting work. I really enjoyed this study, and not just because it was about spine. It is a prospective cohort study. It is graded level 2, but it is quasi-randomized because basically you have 2 different hospitals that treat patients with osteoporotic vertebral fractures in a standardized but different way. One does 2 weeks of bed rest, and then the other basically, treats symptomatically and allows mobilization, function, what have you. I treat a lot of patients with these fractures in my own practice. We do work off the approach to bracing from the article of Kim and colleagues, now probably a classic, but published in the Journal of Bone and Joint Surgery, which is basically braces for symptomatic treatment. It's not required, but we do use it quite regularly. I do modify the patient's activities for generally about the first 6 weeks, nothing heavier than 5 pounds or a gallon of milk, but certainly bed rest is kind of like harkening back to the way these things were managed like 50 years ago. But this hospital is doing it. And, essentially they do bed rest with physical therapy in the bed. And they keep them in the hospital for the first 2 weeks. So this included 116 patients that were followed prospectively. They did do a sample size calculation and followed best practices in terms of making those estimates. The average age of the population is right around 80, 81. They had 116 patients total. They also looked at a subgroup of patients, those who had what they call poor prognostic findings. Specifically on MRI, this is a localized high signal and diffuse low signal on T2 weighted sagittal MRI sections, and or the presence of injuries to the middle column in the horizontal section of a CT, computed tomography CT scan. So they have 45 patients in the group with the mandatory bed rest and 37 in the no rest group who had these poor prognostic findings. And what they found was, particularly in the patients with the poor prognostic group, the transition rate to surgical intervention or treatment failure, however you want to look at it, as well as mean vertebral collapse progression is a lot lower in the rest group versus the group that was allowed to basically, treat expectantly. So they say the hospitalized bed rest for 2 weeks reduced the number of patients with fractures who require surgery, and especially so additional benefits in the poor prognostic group. So really an interesting study. They do recognize in their discussion that the translational capacity is probably pretty limited. Of course, keeping patients in the hospital for 2 weeks is just not copacetic with current management practices here, and they are cognizant of that. They say there are numerous countries in which a 2-week hospital stay for bed rest may not be a realistic treatment option as a result of barriers such as limited bed availability, the cost of hospitalization, etc. And I definitely do agree with that. But it does challenge some of the thinking. This was a study that definitely made me think. It made me think about my practice, and I really enjoyed it. And again, while it is appropriately graded as a prospective, it's not randomized, but it definitely has aspects of it that are quasi-randomization. If you look at the demographic table, most of the characteristics are just intrinsically well balanced, and unless there was some type of mechanism through which the patients were dramatically different who seek care at one hospital versus the other, you really wouldn't expect that. So it's like an instrumental variable kind of, and so I'm not sure if you did a randomized study that the findings would really be any different, at least in this context. So I definitely think it's an interesting work. I really enjoyed the read. Depending on the practice setting in which you work, clinical application is probably not that viable. You have to call up your hospital manager, and I'm quoting Nosferatu here, where you're like, "Be my ally." The great movie Nosferatu, by the way, given that it's Halloween. That's what I said to you.
Right?
That's what I said to you. Be my ally, Antonia, when I tricked you into doing this podcast with me. So I appreciate you coming along. And definitely you should check out Nosferatu in addition to this article. And then also Shadow of the Vampire, which is a 2001 movie, really enrich your life here. I mean, this is the service that we're providing to people well beyond just what we're doing with the research. Shadow of the Vampire, Willem Dafoe, Carrie Elwes. It's really a great ensemble cast, and it's about a vampire pretending to be an actor playing a vampire. I know your mind is just blown
I feel
on
like
that.
I'm in Inception right now.
John Malkovich is in it. I mean, it didn't get the attention it deserved, and I want to say it's like a cult classic, but I don't think it's a cult classic. Speaking of cult classics, how about the trauma collaborative care intervention that you're going to discuss as your headline?
This is going to be an interesting cult classic. You and I have very different definitions of cult classics, apparently. So, this is a study looking at the 12-month effects of the trauma collaborative care intervention, a non-randomized controlled trial. Now, the way they did instead of randomizing is they did cluster studies, and you can probably go much more into methodology because I'm going to pick on your brain for the statistics for this study. But they took 6 centers that did an intervention and 6 stunt leaders that didn't do an intervention. And what I liked about this study is that most studies in orthopedics have a positive results, especially ones that are multi-center or involve a collaborative, and the early results were pretty promising, but this is the 1-year effect of it. And it's an unusual study because it didn't have a positive outcome. And so what they did, again, they did this 12 centers. 6 of them didn't do this intervention, and it's a trauma care collaborative intervention. And this intervention really was to try to educate patients and to mitigate potential problems that happen in the recovery phase after trauma. And we know that this is very true for trauma, right? That patients don't prepare for this in advance. This is not something they come in, ready to take care of, as unlike our other elective surgeries. So because of that, you have patients who, may not be ready in terms of functional aspect, might have PTSD, might have anxiety, might have depression from this. So they assessed all these different endpoints. So patient-reported function, and they used standardized cutoffs here and also standardized metrics. Depression, for example, the patient health questionnaire at 9, and then PTSD, they had a bunch of different questionnaires. So it's good that they used all these things. The hardest part about this, at least for me, is that if you're going to use an intervention, you should have the patient use the entire intervention, right? So there are 5 segments of this intervention that they included. And these 5 were, like I said, a TSN handbook, education, peer visits, recovery assessment, and cause before and after the recovery assessment. So they really did have a comprehensive network for patients to utilize. And they did make a good point that, when it comes to patients and families, they can utilize each program component based on their needs and preferences. But I think to really assess a program, you want people to assess the entire program and engage in it. Only 29% of patients did all 5 metrics that were there. So it's really hard to determine whether or not it was actually the program itself that was no different from control, or it's only because 29% of the patients actually engaged in it. That's the first thing. The other thing that I had a concern with is that halfway through that, or part of the way through the study, they realized that PTSD was actually incorrectly assessed. There was an error in the coding of the feedback portion of the recovery assessment. And because of that, it resulted in inconsistent underscoring of one of the domains of the tool for a lot of the patients. So there were 397 patients. Of that, 298 who completed it in the intervention arm got the wrong assessment. So those who were more severe PTSD were actually downgraded. And because of that, may not have received the necessary care that they want. So part of me says, we've all been in studies before. We don't want to stop it and, go back and redo it again. But this is one of those areas and domains, since PTSD was one of their endpoints, that is probably really important for them to look back and say, hey, look, this is something that should have been assessed correctly. Maybe we have to go back and, start from scratch and go for another 12 months, which is incredibly painful. I totally understand that. But when something's assessed incorrectly, that can make a really big difference. So those are kind of the areas I looked at there. The 1-year follow-up was nice. Normally at 6 weeks is when you can first get the assessment, and that's okay. And 6 months is good. But 1 year is really when you can see the differences, especially in patients who undergo traumatic injuries. We don't know what the trauma is in terms of, like, there was a segmentation of different traumas, right? This is it's all grouped into one area of orthopedic trauma. Ankle fractures do the same as pelvic fractures, where you're down weight bearing for a long period of time. So those are hard to delineate and tease out with only, approximately 400 patients in each arm. And the one question I have for you is this 2-stage statistical procedure. And I think it's actually good because it takes variation in programs and patients into account. But what are your thoughts on the methodology in this study?
I think the methodology is quite good. The posterior estimates of the intention to treat effect are definitely, the most conservative and one of the best ways. If you go with just a single stage procedure, there can still be a lot of infection in the methodology, statistical part. So you got to do that 2-stage, just like you guys do with the joints. You know what I mean? But in all seriousness, I do think that was a nice statistical approach. At the same time, there's a lot of material issues, all of which you pointed out already. The low adherence, or whatever you want to call it. 29% of patients in the intervention group actually got everything that they were supposed to get. So it's one thing if you have a negative study. It's another if it's a negative study, but you don't really know why it's a negative study. And there's no amount of methodologic, fancy outfits that's going to change the baseline issues with the material data. I think that the conclusion is especially salient and also thought provoking, because they say that the program as delivered did not have positive effects. They do think that improved compliance or targeting specific subgroups, I think that's really where the money is. That someone who has a very small, non-significant injury probably doesn't need this kind of thing, and we're really talking about where the value is in people with very devastating limb loss, or open fractures with a lot of soft tissue loss, pelvic fractures, acetabular fractures, spine fractures, probably, especially if there's neurologic deficits. But yeah, ankle fracture, or probably distal radius fracture. This is not going to.
Not so much. They're not calling in. They're getting back to work and trying to get back to activity. So maybe not a blanket one, but maybe nice to see in more, if they only used one injury, what if they did faceted injuries, right? So, if they're a polytrauma, then potentially this would be a really good assessment for them and useful. So if they narrow their patient population, maybe this could be really useful.
All right. Now it's time to move into the Your Case is on Hold featurette. Dr. Frankenstein from anesthesiology is calling. It's Dr. Frankenstein. Yes. Okay. Sorry about that. But yes, the next case should be Hans Delbruck. Hans Delbruck is not ready to go because they dropped his brain on the floor. So you have patient AB normal is the next case that you want to bring. No, we're not doing AB normal today. We're putting, for the first time, we are putting the case on hold. We're putting the case on hold on them. Agevada, ihr Jatin, tun mir dieselbe Sach jedewach. I'm speaking to Dr. Frankenstein in his own language there.
Take that.
Yep. Most people think that Dr. Victor von Frankenstein is German, but he's actually, if you read the book, he's Swiss. Another fun fact. Arts and Humanities isn't just in the JBJS issue, it's also on the podcast.
Mic drop.
Anyhow, back to the horror stories. This article that we are covering is Choose Wisely, Surgical Selection of Candidates for Outpatient Anterior Cervical Surgery Based on Early Complications Among Inpatients. This is by Carlson and colleagues. There is a visual summary. In our courses that we teach about methodology, and when I talk to my research team, we talk about the notion of do it first or do it best, one or the other, right? And I definitely think that this paper has gotten where it is because they're talking about outpatient anterior cervical surgery. The Choose Wisely has nothing to do with the Choose Wisely program as popularized, but it's about outpatient anterior cervical surgery, which is an emerging concept that, previously all of these kinds of procedures, ACDF, cervical disc arthroplasty, anterior cervical fusions, they were all done inpatient, at least an overnight stay. And now, as with total joints, of course, there's a move to, if you can, do these on an outpatient basis and not have the patients admitted. But of course, these are procedures that can have serious complications, airway, hematoma, and patients can decline very quickly. So this was a retrospective cohort study of adults at their hospital, single center, over a 2-year period. And they basically looked at rapid response events, and then they looked at kind of acute complications, which is what you're hoping to avoid when sending, patients home. Of course, you don't want to send somebody home who's at high risk of a complication. As we've discussed in the past, it's always amazing how the seeming waterfall of patient turns into just a trickle of events. They have 1,040 patients, but they only have 36 patients with a rapid response event and 24 patients with an acute complication, and that's it. So this entire story is just based on those 36 rapid response patients and those 24 patients with an acute complication. So you can forget about the 1,040. That's just part of the background. They also, in their exploratory analysis, basically included any covariates with p-value less than 0.2 in their multivariable adjusted models. And that's definitely a problem when you look at their table 4 and see that they have 29 covariates that they are considering. So if you actually just did a back of the napkin calculation for appropriate adjustment, this is taking into account the fact that the number of times you roll the dice, the number of times things can come up just by chance. It's a game of chance in this context. It's a roulette wheel every time you're spinning this. And if you're spinning it 29 times, the likelihood that you're going to find significant findings that do not necessarily translate to the clinical reality is actually very high. So they're using a p-value threshold initially of 0.2 for inclusion, and then they're obviously sticking to the standard 0.05. But accounting for the number of comparisons they're making, the more conservative p-value threshold should be 0.002. And now, dear reader, if you will look at table 4 with me, as well as table 5, you will see that they have very few p-values that are lower than 0.02. And they use this convention where they just say less than 0.01. So you don't even know what the actual p-values for some of those other ones are. And I would say, again, that 29 was just the conservative estimate. In truth, there's probably a few more variables that should actually be factored into. This was just a back of the napkin calculation, as I said, just to kind of prove a point. So there are issues here with restricted clinical variation, truncation, issues with power, issues with the ability to detect interactions and secondary effects among all of these comparisons. Sometimes it plays to their advantage. Sometimes it might be something that's actually very important that they're ignoring because they just didn't have the number of variables to give them and the power, and then also the very restricted event rate. So when you get into their table 5, which is where they're actually showing kind of the distilled down effects, the things that they want to emphasize in terms of patients that I guess, shouldn't have same day discharge after these procedures or an outpatient, this type of surgery at a surgical center. Cerebrovascular accident, for example, has a point estimate of an odds of 6.9, but the upper bound is 34 and the lower bound is 1.4. So somewhere between a 40% increase in risk to a 34 times the increase of risk. This is just an incredible lack of precision that allows us to invest in this point estimate or any other. Then they have anxiety. So if a patient has anxiety, I guess they shouldn't have outpatient ACDF. I don't really believe that. But that's just what this is saying. Although they don't anchor on that finding, although it is a significant finding. Then they have ENT surgeon assistance. This is for their complications. If an ENT surgeon is assisting, the odds ratio goes up to it's an odds of 7.07. So 7-fold increased risk of an acute complication if an ENT surgeon was assisting. The problem with that, of course, is that it's not the ENT surgeon who's, unless maybe they're Dr. Frankenstein or first assistant Igor, that's causing the complication. That's a marker for the complexity of the surgery, because the way it's presented would mean if you just didn't have, if, it could be the most complex case on the face of the earth. And if you're just like, well, I'm not inviting my ENT colleague to help, then there won't be any complications. That's the problem. That's not a factual representation of the issue at hand. They have a lot of findings, such as history of myocardial infarction, history of atrial fibrillation. Both of these have almost a twofold increased risk in the odds of the point estimate, but they have very wide confidence intervals, so they're not significant. So they ignore it. So it doesn't matter if they have a history of myocardial infarction. Actually, I think it does. And if you had a larger sample, the point estimate is indicating that this is an important factor to consider. So they have issues with type 2 error. They have issues with factual representation, kind of a erroneous attribution for some of their variables. And it's going to be tough to resuscitate this one. You will need Dr. Frankenstein's clinical skills. We need a consult to kind of piece this back together after what the work I've done, I guess.
And what language do you have to do that in? Does English work or no?
No, I think probably Schweizerdeutsch.
Perfect.
Yeah.
I have nothing else. You just put the nail in that coffin, so good work.
Or the stake in that coffin.
True.
Our Halloween format. So that case is definitely on hold. I think it is, very interesting to be talking about some of these new paradigms in orthopedic surgery as we move a lot of these previously historically inpatient procedures to the outpatient setting. But how informative this particular context is going to be, I have questions about that for sure, if it wasn't already obvious. Now on to our honorable mentions, other scientific articles well worth the read and presented in this October issue of JBJS. Inconsistent reporting of pre-authorization medical criteria for osteochondral allograft transplantation surgery by Taba and colleagues. This is permanently free, so anytime you're listening to this, you can check it out. The efficacy of bone wax and reduction of perioperative blood loss and total hip arthroplasty by a direct anterior approach, a prospective randomized clinical trial by Mortazavi and colleagues with an infographic. Characterization of genetic risk of end-stage knee osteoarthritis treated with total knee arthroplasty, a genome-wide association study by Coleman colleagues, also with a commentary. And then preperitoneal pelvic packing has a greater risk of venous thromboembolism than angioembolization, management of refractory hypotension and closed pelvic ring injury. Patterson and colleagues, 30 days free. So if you are listen to us as you should the day that this comes out, you've got 30 days to check that out if you don't have a subscription, which of course you do. So, so many ways to access these articles, of course. And this also has a commentary. So do see what others think about these works as well. The time has come. We are out of time. We'll try to do better next time. In the meantime, I wish you all a happy Halloween, trick or treat, but your case is still on hold.
So enjoy those treats because you have time to enjoy them.
Yeah, absolutely. And in the coming month, the YCOH, at least half of it is going on the road. I will be in Kent, Ohio at the very end of October and at the University of Michigan in November. So if you happen to be in the area, come and see me talk.
Or join our podcast and enjoy the time we have.
Right, you can listen to me talk all the time.
Thanks for joining us today.